topic because anastomotic leak is one of the most important complications that can happen after any colorectal surgery. So I will ask every student as to what is the relevance of this paper in the middle or in the end, because I think it has got an extremely important message. But so anastomotic leakage is one of the important complications which causes significant morbidity and also adds to the mortality, and also it has long term problems in terms of quality of life issues. So it is every surgeon's endeavor to try and avoid anastomotic leak. So that is the prevention and ensuring that you have done everything correctly. Despite our best efforts, there is an inherent complication rate which cannot be wished away. So the next best option whenever complications happen is to recognize them early and act aggressively and early, so that you can minimize the effects of the complication and also nullify it if possible, and prevent it causing major complications and death. So that is every surgeon's endeavor. So this journal club will address an issue of anastomotic leak after elective colorectal surgery, how you can use the Dutch leakage score, serum procalcitonin and serum C-reactive protein for early diagnosis of anastomotic leak, and what does it do. So Indraja is going to talk us through this. So over to you, Indraja.
Yes, sir. Thank you, sir. Good evening to everyone. Welcome to today's Journal Club. I'm Dr. Indraja, second year DNB resident in Saga Hospital. Today, the topic for Journal Club is anastomotic leakage after elective colorectal surgery. It is a prospective multi-center observational study on the use of Dutch leakage score, serum procalcitonin, and serum C-reactive protein for the diagnosis. The study was conducted by Mazzoni et al. It is a prospective observational study accepted on 27 January 2020. It is published in British Journal of Surgery on March 5th, 2020, and it has an impact factor of 6.939. As we all know that anastomotic leakage is a major complication after the colorectal surgery with an incidence of about 2 to 7%. To limit the clinical consequences like reoperations and readmissions and morbidity and mortality due to the anastomotic leak, it should be detected and treated as early as possible. There are different clinical signs of anastomotic leak, which includes fever, pain, tachycardia, and purulent fecal drain and dynamic ileus. Along with these signs, some other factors were grouped together and to form a scoring system, which is known as Dutch leakage score. It is a tool useful for the specific diagnostic and therapeutic management of the anastomotic leak. There are other several laboratory markers have been proposed for the diagnosis of the anastomotic leak, which includes leukocyte count, serum procalcitonin, C-reactive protein. According to a recent prospective multicenter investigation, this levels of CRP and procalcitonin levels on postoperative day 3 and day 5 should be included in decision making for the discharge after the colorectal surgery. The Dutch leakage score and modified Dutch leakage scores are useful for the diagnosis of the anastomotic leak in early period. The Dutch score is composed of 13 variables that are collected from postoperative day 1 to 5. And modified Dutch score has 4 variables, includes tachypnea, deterioration of the clinical condition, abdominal pain that is not related to the wound, and CRP level of more than 250 milligrams per liter. These are the different variables of the Dutch score, which includes fever, heart rate, respiratory rate, urine production and mental status, clinical condition, bowel obstruction, and facial dehiscence, abdominal pain other than wound pain, and signs of infection like increased leukocyte count or C-reactive protein, kidney function like function test like increase in serum creatinine or urea level, and nutritional status of the patient. These scores were calculated each day for all patients until they were discharged, and also for the patients who were diagnosed with anastomotic leak. The Dutch score of more than 3 and modified Dutch score of more than 1 was considered positive. The aim of this study to evaluate anastomotic leak prospectively after colorectal resection, aiming to determine the specificity and sensitivity of Dutch leakage score, C-reactive protein, and procalcitonin levels. It is a prospective observational study conducted from September 2017 in 19 Italian centers. The study protocol was registered and published before the study has started, and the written and informed consent taken from all the patients who are undergoing for the surgery, and it is also taken the ethical committee approval. They included the patients who have undergone surgery for the who have undergone elective colorectal resection, either minimally invasive like laparoscopic or robotic, or open or converter surgeries, and ileocolorectal resection with intracorporeal or extracorporeal anastomosis, and they also included the Hartmann reversal procedures. They excluded the patient based on the ASA grade 4 to 5 and patients with stoma before or at the time of operation, and stoma reversal without resection, transanal dissection procedures, and in pregnancy patients. They also excluded the patients with ongoing infection before surgery, and they excluded the patients who have undergone hypothermic intraperitoneal chemotherapy for carcinomatosis. CRP and procalcitonin and Dutch leakage scores were performed before surgery on postoperative day 2 and day 3, and the postoperative day 6 was the optional. And the postoperative clinical examination was conducted by the surgical team for the following signs like fever, pulse rate, abdominal pain, bowel movements, and volume and aspect of the drainage. Any complementary investigation that should be done, it is decided by the attending surgeon, and imaging was not performed routinely for the detection of the leakage. And all the complications were registered according to the Clavin-Dindo classification. Some of these complications like leak, wound infection, pneumonia, central line infections, and urinary tract infections. The follow-up was conducted in outpatient department up to 6 weeks after the surgery. Clavin-Dindo classification, it is a classification of the postoperative complications included from grade 1 to 5. Grade 1 is deviation from the normal postoperative period. There is no need of the pharmacological treatment. And grade 2 is requiring pharmacological treatment. Grade 3 is requiring surgical or endoscopic or radiological investigations. Grade 4 is life-threatening complications like single organ dysfunction or multi-organ dysfunction. And grade 5 includes the death of the patient. The primary endpoint was anastomotic leak, which is defined as any deviation from the planned postoperative course related to the anastomosis or presence of pus or enteric fluid in the drains, and abdominal or pelvic collection in area of anastomosis on contrast enhancing CT, and they also defined it as anastomotic dehiscence at reoperation for the postoperative peritonitis. Secondary endpoints were morbidity and mortality rates, readmissions, and reoperations. All the data were recorded prospectively and transmitted to the coordinating center, and any discrepancy was checked and addressed. These are the basal and postoperative C-reactive protein, procalcitonin, and Dutch leakage scores according to the presence or absence of the anastomotic leakage. And the presence of comorbidities are the most significant risk factors for the anastomotic leak. The estimated sample size was calculated based on the estimated odds ratios for ASA grade 1, 2 versus grade 3. Quantitative values are expressed as mean or median values. The categorical data are shown in the percentage frequencies. Differences in the continuous variables analyzed by the Mann-Whitney U-test. Area under curve values are calculated for Dutch leakage score, C-reactive protein, procalcitonin on POD2, POD3, and POD6 for all endpoints. And 0.7 to 0.8 were considered acceptable, 0.8 to 0.9 as excellent, and above 0.9 is outstanding. Differences in area under curve values are analyzed with chi-square test. The optimal cutoff points for DLS, CRP, and PS procalcitonin were obtained by applying Jordan's index. The negative and positive predictive values are also calculated. Patients with anastomotic leak, the values of 3 potential predictors above the cutoff points were considered true positive, and below the cutoff points were considered as true negative. Logistic regression model was built using the presence or absence of anastomotic leak as the dependent variable, and the C-reactive protein, procalcitonin, and Dutch leak scoring systems as explanatory factors. Using logistic transformation of linear predictors, the probability of anastomotic leak related to the different combinations of the predictor values was determined, and all the statistical significance level was fixed at probability of less than 0.050, and statistical analysis were carried out using Stata software system.
Okay.
Critics. Yes, sir.
Good. There is first question from Dr. Dayanand Nuli. Good evening, sir. Welcome to the Journal Club.
Good evening, sir. Good evening.
Good evening. So, Indraja, will you say what impact factor is?
Sir, impact factor is
you don't know?
no, sir.
Okay, Pavan. Pavan, are you there?
Hello, sir.
What is impact factor?
Sir, that is what I have to say. Review of articles in particular journal, sir.
Not review. Not review.
Site, I mean, reference kind of thing.
Hari?
The number of times and paper in the journal cited during a year, sir.
During a year, yeah. So basically, impact factor is the number of times a particular article from that journal is cited in various other journals or various other publications. So that the higher the impact factor, more times is the particular article or the particular journal has been cited, whether it is in textbooks or in publications or other journals and other articles. So higher the impact factor, better the journal is. So the New England Journal of Medicine is one of the most reputed journals, and it has an impact factor of around 22 or something like that. And the best surgical journal with the highest impact factor is Annals of Surgery, which has an impact factor of around 17 or 18, if I'm not mistaken. Sir, Shanai sir, would you like to add anything?
No. So what you told is right, that higher the impact factor means it has been cited. So as somebody has already put it, no, citation.
Citations,
So
yeah.
one of the important thing is now there's also called a citation index now. So like you have the impact factor. So the idea is that whenever an article is written, it should be of that standard. That's the whole purpose of
Correct.
this.
Yeah.
So,
okay. Right now, Pavan, would you like to critique so the journal so far? What has been done? What has been covered? Pavan?
Sir, am I audible, sir?
Yeah.
Sir, so far, so this is a recent study, sir. 2020 paper. And the topic is also relevant, sir, regarding anastomotic leak and comparing with the Dutch score.
Okay.
And having a good impact factor, sir, 6.9.
Yes.
And it's a prospective study, sir.
Correct.
Yes, sir.
Anything else?
They clearly mention the inclusion and exclusion criteria.
Correct.
And also primary and secondary points, sir.
Correct.
Yes, sir.
What else?
Pavan, if I am permitted to come in.
Yes, sir.
What is the type of this study? First you comment on that. Type means she has already mentioned. First slide.
Prospective study, sir.
Prospective what?
One more very important point is there. Yes. Prospective. See, remember the first slide. Yes. Observation.
Observation, sir.
So what is your comment on that? You start from there,
Sir, that means we are recruiting the patients and we are following the patients. That what happened?
We can't ignore that, but still observation study is better, or
yes,
what are the other studies are better? That's what my question. You understand? Yes.
What are the other types of studies, man?
Yes.
Sir, some retrospective studies are there and randomized control studies.
Yeah.
And meta-analysis are there, sir.
No, but he's asking the type of studies, those are all fine. But here it was an observational study. What other things that you can do? When you operate, what do you do?
Sir, we will include that.
You do intervention, man.
Intervention.
Interventional studies. So if, for example, you add a drug or you add some particular procedure, you are studying a particular procedure, you do it in some people and you don't do it in some people. So that, you are studying the intervention. So observational studies, you just, you are observing what is happening in the patient. You have, you have set your protocol. You are looking at so many factors and see what is happening. So that is just purely observational. But you can also do interventional studies where you say, maybe you can divide the two groups. In one group, you are not doing anything. In another group, you are doing an intervention. Then you compare the two groups and see whether there is difference between the two groups. So that is interventional studies. Then what you said is about case control studies, cohort studies, randomized controlled studies, and retrospective studies. Those are all definitely types of studies. But what Professor Shanai was asking was that. Anything else, sir?
So yeah, I also want him to understand. This is an observational study of the colonic malignant, whatever resections. Now, is it comparative study would have been better or this study? This is my question to you. If comparison, what comparison? You understand my question, Pawan? Or
Yes,
whoever who is presented. Yes, Indraja or whoever it is.
Hari?
Sir, this study topic is chosen to see whether the particular criteria will affect the factor. So here we can't do comparison, but
No, I'm not trying to say you compare with any other Dutch scores with another score. I didn't mean that. What I mean to say was, is there a difference between left-sided resection anastomosis or Hartmann's versus right-sided colonic resection anastomosis? Is there a difference? That is my question. Critic means this like that. Yes. Do you have some idea about it?
Like in our last study also, sir, the different study is matters, sir. But I think the aim of the study, what we choose, no, sir, based on that, we have to select the study, what type of study, what we are going to do, like how we observe that. So definitely there could be a difference there.
So what I was trying to tell is also there is a comparative study. So yeah. Even in this colonic resection, it is a right-sided resections are different from left-sided resections. Okay. There are different factors, different reasons, etc., etc. Okay, that may not be appropriate at present. So that is what is the analysis. Ravishankar, please.
Yes. Yeah. Hari, anything else to add to what Pawan said?
Yes, sir. For the studies, sir, the definitions are good, sir. They have clearly explained about the anastomotic leak and also the endpoints also good. And again, sir, since it is about anastomotic leak, sir, I couldn't see anywhere about the surgical details or surgeon expertise here. Or those details should have been there. It would be better, sir, because it's about because they mentioned only experienced surgeon. That's all. And also any other details about chemotherapy, because those factors also influences leak. So patient further details could have been added, sir. So those are the points I wanted to add.
Yeah, I think, see, the thing is, whenever a study of this magnitude is chosen, and if you look at the collective cumulative, the anastomotic leak rate, which is very good and very acceptable, you have to presume that the quality and the ability of the surgeons is not in question. So I think they probably have standardized the procedures, and because I think what has happened is when the classic trial came and when this TME came, all the surgeons in Europe were video recorded and standardized. So what has happened is, and then there is a mentoring process. So basically, because of that, though you can't generalize it, but generally the quality of surgery across the board is of a fairly high standard. So that is why they probably presumed that is why they have not mentioned it. but maybe it would have been, appropriate if they mentioned, because in a proper scientific study, nothing should be presumed. Everything should be stated. So on that count, I agree with you. But the background to that, I have explained to you already. I think because if you look at their cumulative this one anastomotic leak rate, which is, and the complication rate is very good. So I think the standard of surgery and the standard of substance is pretty decent.
Okay.
Any other critique as far as the title and factors which are taken into consideration? Dr. Indraja or whoever, Hari.
Indraja, you put up your critique now.
Yes, sir. Sir, they didn't mention about the tumor characteristics, sir. Like,
no, that what
you mean to say the for let us say a T1 tumor, the leak rates are less compared to T4 tumors?
like that's I thought like that.
I think the one
And
other thing
distance of the tumor from the like anal verge and this.
See, I think, because see the scope of this paper is to not look at the operating characteristics or anything.
Yes,
all of those probably have been standardized. So they are only looking at the anastomotic leak. So and you cannot, I think all those details, if you give, I think the paper will become too elaborate. Okay. And many of those details probably would be unnecessary details as far as the this paper is concerned.
Okay. So I have one doubt, sir.
Yeah.
In the exclusion criteria, inclusion they have mentioned as a Hartmann reversal. And in exclusion, they have mentioned like a stoma at the time of the surgery or before the surgery, sir.
Yeah, correct. I think that is that. But the thing is, if they have, what they have done is, if they have reversed the Hartmann's, where if they have, if the patient has not undergone any resection, then they have excluded it. If they have reversed the Hartmann's, see, obviously, I think that is one point where stoma will be present before, but then the stoma will not be present after the surgery. So I think there is an element of doubt about that. You are right. Yes. Because all Hartmann's procedure will have stoma before surgery.
Yes, sir.
Yeah,
yes, sir.
Yeah. That there is an element of doubt in that. Anything else, Abdul?
Can I come in?
Yes, sir, please.
And Dr. Indraja,
yes,
question
sir.
to you. What is your comments on the Dutch scores? Just a comment.
Sir, it is a scoring system that includes most of the clinical parameters and one of the 2 laboratory investigations
So
that we can easily perform, sir. 13 variables it includes, sir. It includes 13 variables, 11 clinical parameters and 2 laboratory tests, sir.
I agree with you. 11 clinical variables.
Yes, sir.
Day to day it happens, so you can easily perform.
Yes, sir.
But what is the most important thing lacking? What I'm trying to tell is that more the number you add,
yes, sir.
more. Say like you say Apache 1, Apache 2, so many scores.
Yes, sir.
Then what happens is the calculation and other things becomes difficult sometimes. Yes, so sir. It would have been nice if you were to have a little bit of a smaller version of this.
They have done, sir, modified that only 4 parameters, which is good.
That is like
they applied the classical DELC score in this study, sir.
But actually, both DELC, I don't know about the DELC, modified DELC, but DELC study has been validated by a prospective randomized control trial, which shows its effectiveness. So there is no doubt about its effectiveness, but modified DELC, I'm not sure. But they have applied classical DELC in this one. Anything else, Kavya? Kavya, you've been silent.
Sir,
anything else to add to this?
No, sir.
Niranjan, are you there?
Yes, sir.
Anything to add, Niranjan?
Sir, in the initial thing, what I noticed was in the inclusion criteria, exclusion criteria, they have not mentioned emergency surgeries, but like in exclusion criteria, but later they have excluded emergency surgeries also.
surgeries. Yeah, that's right.
There is
What is your thought on what Kavya, this one Indraja asked? See, they have said that if the patient had stoma before, they have excluded it, but then they have
correct.
included Hartmann's reversal. So that's a slightly
That is what,
controversial.
there are 2-3 issues which the paper is not very clear, where they have contradicted themselves. That is one thing.
Yeah.
And the second thing is also on how they investigate when they have a leak.
Correct.
It is like, or there is no standardization there. Where like in each patient they have done this in a systematic way. They have just mentioned it as or. Like who, whether it is depending on the surgeon who has decided or what, and when they have done that investigation.
They have actually mentioned that the
know.
rest of the investigations is at the discretion of the operating surgeon.
So if they had standardized, then it would have been probably easier to decipher the values more accurate.
Correct. I agree. The thing is, the problem with going by an operating surgeon is depends on that particular surgeon's attitude. If somebody may be very aggressive and they may do contrast enhanced CT on day 3, and some other people may decide to wait and watch, depending on how aggressive or how passive you are. So I think that leaves the paper for interpretation. If there is standardization, it makes it easier.
Because
yeah, I agree. Shrikant, are you there?
Of the end results also.
Yeah. Shrikant, are you there? Shrikant is not there today, I think. Okay. Sir, Nuli sir, your thoughts so far?
Sir, I was just thinking about the type of anastomosis, sir. They have not mentioned on that. Yeah. That also has to be taken into consideration, sir.
Sir, I think I agree. I think a lot of these points like, the tumor characteristics, tumor stage, it's a type of anastomosis, skill of the surgeon. But all these things, they have, kind of standardized probably and said we are only looking at the anastomotic leak once it happens. So maybe, so that is why they have not mentioned it, I think.
Okay, sir.
Okay. Carry on, Indraja.
Yes, sir. When coming to the results, the study conducted from September 2017 to 2018, and in this period, around 2,700 resections were performed. Around 1,546 patients were enrolled in this study, and 1,100 patients were excluded. The overall neoplastic disease was noted in 68.8% of the resections, and 83.5% of the patients underwent minimal invasive surgeries. The reasons for exclusion of the 1,100 patients include stoma before or at the operation or refusal of the consent, emergency procedures, and stoma closure without resection, transanal procedures, ongoing infection, and ASA grade 4 and 5, and patients who have undergone HIPEC. And the anastomotic leak was noted in 76 of patients. It is around 4.9%, and the mean time of the diagnosis of anastomosis leak is 5.94 days, and the range is from 1 to 31 days. The anastomotic leak is confirmed by clinical examination on 23 patients, with CT with contrast in 30 patients, by intravenous contrast in 22 patients, and by endoscopy in 1 patient. The degree of severity of the anastomotic leak was classified according to the Clavin-Dindo classification. Around 69 patients, there are grade 3B complications, and in 6 patients, there are grade 4B complications, and in 1 patient, there is grade 3A complication. And the overall morbidity rate is 30.2%. Of this, 447 patients had grade 1 to 2 complications, and 185 patients had grade 3 to 4 complications. The operative mortality rate is 1.3%, and the 107 patients required reoperation, and 14 patients are readmitted to the hospital. The mean duration of the postoperative hospital stay for all the patients is 7.89 days. With respect to the anastomotic leak, the Dutch leakage score performed better than the CRP and PTC on postoperative day 2 and day 3, and CRP had better sensitivity and specificity curves on POD 6. Morbidity predicted poorly by all laboratory values and clinical score, and mortality predicted best by procalcitonin on POD 2 and by Dutch leakage score on POD 3 and POD 6. These are the images showing the Dutch leakage score is better performed on the POD2 and POD3, and CRP is better performed on the POD6. There is no difference between the area under curves was statistically significant, and logistic regression confirmed the statistical significance for all the three predictors with regard to the anastomotic leak. The maximal positive predictive values are 21.3% on POD2 and 33.4% on postoperative day 3 and 47% on postoperative day 6. The maximal negative predictive values are 99.0, 99.3 and 99.2 on postoperative day 2, 3 and 6 respectively. These are the positive and negative predictive values of the CRP and the procalcitonin and Dutch leakage scores. Yes.
Right. Is it Dr. Ramakrishna there? Not here today. Right.
Yes.
Okay.
Yes.
Whom shall we ask? Hari, what is your critique so far for the results?
Sir, the reasons for exclusions were clearly mentioned. This many have been excluded. What reason exactly, sir? And statistical analysis also seems to be. I don't feel any other against at this level, sir.
Okay. So only problem is what? Lot of exclusions.
Yes, sir.
Yes, sir.
But can you understand the reason for exclusion?
Yes, sir. Multiple fact that is has to happen, no, sir, because whatever they mentioned, it is correct only. Excluded reasons.
Yeah. No, but what is the major reason for exclusion?
Stoma before the
Stoma before or after the surgery.
Yes, sir.
So the thing is, if there is stoma, and it is supposed to be protective. So obviously, if you then study leaks in the in those patients, and probably it will be irrelevant, isn't it? So they have to exclude this group. So which about 50%, more than 50% of them is with the stoma. So that obviously is I think the exclusion criteria are correct.
Sir, but stoma before surgery, like in Hartmann's,
yeah,
I don't think it will alter the anastomotic leak rates that much when you reverse it.
Correct. But what they have done in the end is if there is stoma before and after, they have excluded it. So I think they have probably excluded Hartmann's completely, I think.
That is what the data is not very clear.
Not correct.
Because
that is the thing. Yeah, that
we
is
would
what.
have had a large number of patients. I think in Europe and all that, Hartmann's is a much more major this thing. Like
correct.
In large numbers, they get patients with Hartmann's.
Correct. So I think there is no clarity about what has happened to the patient with Hartmann's procedure.
Yeah,
because
Ravishankar,
yes,
in fact, Hartmann's looks easy when we do, but reversal is more difficult.
Very, very difficult. I agree with you totally, sir.
So that is the reason. That is why initially I made one small comment that if they were to confine themselves to only one side of the colon, it would have been better. That is what I was trying to tell.
Yeah, yeah.
Or if you are compare two different arms itself, left versus
right, sir. Yes.
That's what I was trying to tell.
Yes, yes, sir.
I have one small point to make here is
yes, sir.
Indraja.
Yes, sir.
You have mentioned CRP. They have taken consideration CRP, procalcitonin. My question to you is why not lactate? Just like that. You know, lactate also is one of the important marker of sepsis.
Yes.
So why not lactate is a very good question.
Yes. So can you give me some reasoning? Or in Indian scenario, for example, if you do lactate versus procalcitonin, for example, does it make a difference? Or definitely procalcitonin is better? Reason is it is very specific.
Yes, sir.
Understand? Lactate can be elevated if you have skeletal muscle breakdown, including calf muscles or including cardiac events. You understand?
Yes, sir. Yes, sir.
Patients with the sepsis, they can have very many reasons for a elevation of the lactate, but not procalcitonin.
Okay.
But then why not you do in every patient? Is it routinely done, or is it third day, fifth day? One factor, important factor is
why is procalcitonin not done very frequently?
Because
they have also mentioned that
cost effectiveness.
Correct.
Yes.
Very important.
Very
Okay?
expensive.
Yes, sir.
It is
Yes,
very
sir.
expensive.
So that is why you take into clinical consideration of the score,
Yes, sir.
whatever you have mentioned, and adding on few other facts. CRP, do you think it's very specific or
No, sir, it's not specific.
again, it is also not specific?
Yes, sir.
But that there is, Indraja, you have to counter that by saying
Yes, sir.
that if they have compared independently CRP and procalcitonin and found that CRP is equally as effective in predicting anastomotic leak as procalcitonin. So there
You
is
have-
no point wasting a lot of money.
Yes,
You
sir.
can as well use CRP.
Yes, sir.
In fact, you gave a level, no, 256 or somewhere you mentioned. I don't
Yes,
know.
sir. Yes, sir. It is in the modified Dulk score, sir.
Yes.
250.
So if it is 30, 40, probably may not be of that relevant in this scenario. Is it clear?
Yes,
So
sir.
if that is very high, then there's no point in doing procalcitonin. That's what is important. Correct, Ravishankar?
Yes, sir. Yes, sir. Okay. Show your critiques,
Yes, sir.
Indraja.
Sir, against this, they didn't mention what in anastomotic leak patients, they didn't mention what they did. Whether it is relevant or not, I'm not sure, sir. I have mentioned. And readmissions and reoperative details and the reasons for 14 patients were readmitted, sir. We don't know the reasons for readmission.
See, I think basically, see, this is what you should think.
Yes.
See, you are looking at predictive value of Dutch Dutch leakage score,
Yes, sir.
CRP, and procalcitonin. So how does it matter whether the patient was readmitted or not? So I don't think those things are relevant. As long as you have made the diagnosis of anastomotic leak, and they have actually said, how many patients were reoperated and all that they have said. But the details of this one is not relevant again, because as long as the reanastomosis, the anastomotic leak was confirmed and the tests that you have done have either a strong positive predictive value or a negative predictive value, other things are not in the purview of this study, because you can't keep on giving so much details. When you look at one particular patient's episode in the hospital, you can write a thesis about one patient. There will be so much data available. All the data need not be furnished. You have to focus your data to the current question that you have asked. So whether why the patient was readmitted, as long as the patient was readmitted for sepsis and anastomotic leak was confirmed and that was dealt with, that is enough for you. Or if that patient had complications, they have quoted all the complication rate, mortality rate. So those things are relevant. The endpoints were what? Anastomotic leak and morbidity
and mortality rates. Yes.
So readmission is not it is not one of the factors they were studying. So they don't need to furnish the detail.
Okay, sir. Okay.
Hari, Abdul, Hari, I have already asked. Abdul?
Yes, sir.
Any other
No, sir,
points?
nothing else to add.
Kavya?
Else.
Kavya, madam?
Sir, nothing else.
Nothing else. Okay. Right. Carry on, ma.
Yes, sir.
Indraja.
Yes.
Sir, I have a doubt.
Yes, sir.
Sir, this anastomotic leak was diagnosed by endoscopy. I don't know.
Sir,
what is
I think
on that, sir?
I think basically, yeah, you asked that question. Basically, when you put the scope, they probably see a gap in the anastomosis. And I think that is how they diagnosed in one patient.
Patient they have done.
Yeah. Maybe they were not sure. I think so. That is why they have done the endoscopy and the sigmoidoscopy or whatever it was. And they might have seen a gap, or when they blow the air, I think they could see the air escaping out of that particular point. I think that is how they made the diagnosis, I think.
Okay, sir.
Okay. Continue, ma.
Yes, sir. And coming to the discussion, the addition of laboratory markers to the clinical scoring system is useful in the exclusion of the anastomotic leak in early postoperative period. The bias in the study is exclusion of the 1100 patients, mainly because of the presence of the diverting stoma. And another confounder is the proportion of the minimal invasive resection, that is around 83%. That is higher than the reported around 40 to 46% in the same period in nationwide database. The anastomotic leak detected in 76 patients, that is around 4.9%, which is compared with large cohort studies, which is around 2.7 to 10%. And the mean time of diagnosis of the anastomotic leak is 5.94 days versus 12.47 days in open colorectal resections. It remains difficult to establish whether this was actually earlier diagnosis, as the use of both clinical and serological markers of the anastomotic leak diagnosis in present study may have focused special attention on this diagnosis, whether this was simply an earlier appearance of anastomotic leak due to the high rate of minimal invasive resections. In any case, this finding deserves particular attention when considering the increasing use of enhanced recovery programs in colorectal surgery.
Okay, so
Yes,
this is the point I wanted to ask. Abdul,
Yes, sir. Tell me, sir.
what is your comment on this? The last statement. What is your comment?
Sir,
Kavya?
Sir, especially in ERAS, when we are discharging the patient more early, we may make some anastomotic leaks when this may help in predicting whom to discharge and when to discharge.
Absolutely, you hit the nail on the head. I think that is the most important thing. See, when you practice something as I think as exciting and radical as ERAS, you have to have definitive criteria. What they were doing all this time was the clinical criteria, when the patient was looking well and patient had passed play tests and all these things. So now you have two important, one is the Dutch leakage score, other one is the CRP and procalcitonin. These have excellent negative predictive value, which means if the test is negative, there is no leak. So that is extremely critical. So as long as you have a negative predictive value of around 99.3%, that is on day 2, day 3, and day 6, uniformly it is high, which means if the test is normal or low, there is no leak. So that is excellent. The positive predictive value could have been a lot higher, 21%, 33%, and 45%, which is pretty decent, but not, you can't go based on that and discharge the patient. But you can certainly, in patients whom these values, if the Dutch leakage score was less than 4 in the classical Dutch leakage score or less than 1 in the modified Dutch leakage score, and if the CRP levels were set at 123, 256, whatever, if it was less than that on the days, they have given the different CRP levels for different days and procalcitonin also for different levels for different days. If the values were lower than that, that means that patient has no leak. So that is another, I think Kavya said it very well. So because when you are discharging patients early, you should have objective criteria on which you can go based on which you can discharge these patients. So for that, this study has had a major impact, because if the Dutch leakage score is low, if the procalcitonin and CRP levels are low, then you can be fairly certain that this patient does not have the leak and you can discharge this patient. So that is the most important take home message from this study. Okay.
Sir, on POD 3 and POD 5, so you routinely advise these investigations to be done?
Sir, I think, yeah, see, basically the enhanced recovery program, majority of the patients are discharged on day 2, day 3. So previously what they would do is, if the patient is mobile, if the patient is able to tolerate oral diet, if the patient has passed play tests and clinical parameters were good, they would discharge them. But now if you do on day 2, I think the Dutch leakage score on day 2, day 3 is very good. And the CRP is on day 3 and day 6, and the procalcitonin level is on day 2. So if you do either of these scores on day 2 or day 3, and if the levels are normal or lower than normal, then you can safely discharge this patient. I think that is the message.
Yes, sir. Yes.
Ravishankar, can I say something?
Yes, sir.
Yeah. So now a little bit of difference here about the take home, in the sense.
Yes, sir.
Suppose there's a situation of a CRP elevated, and look at the variables which she has given. There are some 12, 13 are there, correct? No?
Yes, sir.
So do you think out of which, even if one is there, can you show that variables? Is it possible to go back quickly? There was a way tachypnea, tachycardia, and all that things.
Indraja, go back to that thing.
Do you think that if they are present, even if a ERAS patient, you think they will discharge? This is my question to.
No, sir, they won't discharge.
So what I'm see.
Yes, sir.
No, I wanted to know those not laboratory, the clinical criteria.
Yes.
Go back to the DLS.
Yeah, that's why you put a slide numbers next time onwards.
Okay.
I always tell. Now, for example, you take a ERAS patient. I'm just giving an example to you, Ravishankar.
Yes, sir.
Somebody's respiratory rate is 40, for example.
Yes, sir.
Do you discharge? You will
no,
not.
Sir. You won't discharge.
Okay. Suppose one of the early part of the sepsis is urinary output dropping, especially abdominal sepsis is a gram-negative sepsis.
Yes, yeah.
Nobody will discharge.
Correct.
Now, mental status, deterioration, bowel obstruction, gastric retention, facial descents, abdominal. So what I'm trying to tell is, if out of this fever, heart rate, other than maybe a thrombophlebitis and other things, none of the things are present, nobody will discharge these patients.
Correct.
What I'm trying to tell is, if your patient has got fever and increased heart rate, respiratory, remember, PGs should not get confused this for an Alvarado score. Okay. You know, Indraja, what is Alvarado score?
Yes, sir, in acute pancreatitis.
Acute appendicitis.
Appendicitis, sorry, sir.
What is the difference between this score and that score? There also labs are taken, leukocytosis is taken, correct?
Yes, sir. But
what is, that is a pre-operative score.
Yes.
Yes.
And this is a
post-operative
score. So if you look at these clinical variables in the day-to-day practice, I want people, our postgraduate should concentrate on these things.
Yes, sir. See, I think, the study is very clear.
Yes.
The Dutch score is better than
either
CRP or the procalcitonin in predicting the anastomotic leak. That they have shown.
So
but the statistical significance is not there. So I think if the patient is ready for discharge, if you objectively do either a CRP or a procalcitonin, and if that is also negative, if it is high, then you will keep the patient. If it is low, then you can discharge the patient. So that is the thing. So I think the Dutch score has been validated and CRP also has been validated. So if you combine the two, then the chances are you are going to be safe when you discharge this patient. That is the take-home message.
So postgraduates, when you have an anastomotic patient in your ward, second day or third day, you concentrate on these variables which are routinely done. That is what you learn in the ward rounds. That is what I want suggestion.
Yes, sir. Yes, sir.
That's
Niranjan?
Sir, I agree with Shanai sir's comment, sir. Isolated lab values don't have any value if they don't have any of these clinical criteria. Because CRP can go up immediately after surgery also. Although PCT may not go up, but CRP can be there high in any of those patients post-operatively.
Yeah, I agree. See, the basic, what I was trying to convey is that...
Yes, correct. In the ERAS criteria, where they discharge the patient on the second day or the third day, there is a definite relevance to this. When there are no clinical findings, you do that, and if there is a warning with respect to high CRP or
keep them. Otherwise, discharge them. So that is the take-home message. See, I think postgraduate should be very clear. There is nothing will replace clinical judiciousness, clinical, careful clinical monitoring of the patient. No investigation will replace that. So you have to go by your day-to-day examination of the patient and comparing the patient. So that is why we call this SOAP regime. So patient, subjective assessment, objective assessment, and assessment of the total, global assessment of the patient before you make a plan. So the SOAP regime has to be implemented every day. So clinical acumen, clinical decision making, clinical, observation will not be replaced by any number of investigations. What this paper is trying to say is that the Dutch, the leakage score is better than either CRP or procalcitonin, but taken in combination, it can help
definitely
make the decision a bit more objective and easier. That's all. Okay.
Yeah. I would also like to add that paper has told about 3rd day and 5th day. That does not mean that you should do only on this. Suppose patient is fine on 3rd day. If it is 4th day deterioration in this, whether it's a respiratory rate or heart rate, so you are all the time you are justified in doing.
Yes.
Only important message here is do the clinical examination, because you can't go on doing it every day. You understand?
Yes.
So
Yes.
this applies to imaging also.
Yes.
Just
Sir.
because you suspect, you can't go on doing CT scan. 3rd day CT scan, you do no leak. That doesn't mean 5th day you do it again, or 6th day. So
Correct.
based on these are the important parameters.
Yes. Okay. Correct? Carry on, ma. Go back to the where you were before now. I think there are some.
Sir, and I had one more this thing. So
Yes,
there
sir.
is one entity called Niranjan here.
Yeah.
There is one more entity called as radiological leaks, which may not be clinically relevant.
Clinically relevant, yes.
So will these markers go up? So, like suppose suddenly you have a high CRP, you do a CT on 2nd or 3rd day, and there is a radiological leak. Patient doesn't have any other symptoms, signs.
Yeah. So what in those situations is don't discharge them. Just follow the patient and see how they do. Majority of them, you may not need to do anything. It will leak. It will settle down. Yeah, it will settle down. But that again, that is why this is helpful in helping patients to be discharged or kept in the hospital. So that is the relevance. You are perfectly right, because radiological leak rates are anywhere between 22 to 40% in especially in left-sided anastomosis. So, but in such patients, many of these radiological leaks may not be clinically relevant. So in such patient, if the CRP has gone up, keep the patient, observe them. If they get better, maybe you may need to continue the antibiotics or whatever. Keep, and then if once the patient settles, you send them home. I think that is the.
Ravishankar,
Yes,
you please permit me to go. Before I go, I just one small observation and comment.
Yeah.
That is, in the day-to-day practice, what happens is decision making sometimes become difficult.
Correct.
Because post-operative patients, 2nd time explode, sometimes 3rd time. So these are all called a refractory peritonitis. It goes on primary, secondary, even tertiary.
Yes.
So these are the values which may be extremely useful. Procalcitonin and CRP, etc. Beyond that cutoff level she has mentioned.
Yes.
Where sometimes even a radiological investigation may not reveal whether to explore or not explore. So that also point to be noted.
Yes,
correct?
sir. Yes, sir.
Thank you,
sir. Thank you. Okay, continue, ma.
Yes, sir. And with regard to the laboratory markers, a significant difference in post-operative values were observed in patients with anastomotic leak, those without, and both C-reactive protein and procalcitonin levels showed that typical and peaking at post-operative day 2 and post-operative day 3. Different clinical scoring systems are also evaluated for the early diagnosis of the anastomotic leak, have been suggested and externally validated. These are the different levels of the CRP and procalcitonin and Dutch leakage score on postoperative day 3 to day 2. And the Dutch leakage score is appeared to be the best predictor of anastomotic leak on postoperative day 2 and day 3, although it is not statistically significant. And this score was devised to reduce the delay in diagnosis of anastomotic leak and related mortality. It is originally based on 11 easily accessible and 2 recordable clinical 2 laboratory tests. Its scores ranges from 0 to 20 and cutoff value is 4. And then it is simplified as a modified Dulk score, which includes 3 clinical parameters and 1 laboratory test. The scores range from 0 to 4 and cutoff point is 1. It is maintaining the same diagnostic accuracy as when compared with the Dulk score. In the present study, the original Dulk scoring system was applied. The addition of the procalcitonin to DLS and CRP improved the both cumulative positive predictive and negative predictive value of the test for the presence of or absence of anastomotic leak. The procalcitonin, it is the best predictor of the mortality on postoperative day 2, confirming its role in patients with ongoing sepsis. Although the previous studies suggested that procalcitonin should not be used routinely as biochemical marker because of its poor cost effectiveness. The DLS and CRP and procalcitonin on postoperative day 2 and day 3 may be useful to predict or exclude the patients with clinically severe anastomotic leak and also patients with potentially uncontrolled sepsis and death. Yes. Can I continue, sir?
Yeah, continue. We have discussed a lot of these things already.
And against the study includes the large exclusion criteria. As they mentioned, there is more minimally invasive procedures and there is no information about the diagnosis, sir. Shall I continue, sir?
Yeah.
And review of literature, the anastomotic leak after the colorectal surgery, it is a life-threatening complication. The incidence is at about 1 to 19%, and mortality rate associated with these complications ranges from 3 to 20%. It accounts for about 30% of all deaths after the colorectal surgery. The different risk factors for anastomotic leak includes tumor location, tumor size, and male gender severe malnutrition, and tobacco use, operating term more than 180 minutes, and preoperative neoadjuvant therapy and steroid therapy. According to a study conducted by Stomack et al., that is anastomotic leak after the surgery for colon cancer on long-term survival, they aimed at to investigate the long-term impact of grade 3 anastomotic leak in large population-based cohort study. They included around 22,000 patients. They concluded that relative survival analysis showed strong negative impact of anastomotic leak on long-term outcomes of patients resected for the colon cancer. And another study evaluating Dutch leakage score in diagnosing anastomotic leak in colorectal surgery. It is conducted from 2015 to 2016. It included DULC and modified DULC score were applied for each patient retrospectively, and they noticed anastomotic leak in 8 patients. And they concluded that DULC and modified DULC scores were excellent tool for excluding anastomotic leak after colorectal surgery. And they said that these are easily calculated and do not require any sophisticated laboratory or radiological tests. According to a study conducted by Selmi Award et al., the assessment of perioperative risk factors for anastomotic leakage after intestinal surgeries, it is a prospective study, included 315 patients who have undergone bowel anastomosis for small intestinal and colorectal pathology. And they concluded that preoperative serum albumin level and emergency operations are the independent risk factors for the anastomotic leak. And leakage should be suspected and predicted in cases with high respiratory rate, heart rate, and high CRP levels. According to a study conducted by Dams et al., the prediction on diagnosis of the colorectal anastomotic leakage, a systemic review of the literature. They reviewed the all available literature on the diagnostic tools for the colorectal anastomotic leak. The CRP measurement should be the part of postoperative laboratory routine, at least on POD3 and POD4. And cytokine measurement among the other measurements of the peritoneal drain fluid is promising and could justify the routine placement of the juxta anastomotic drain. When come to the management of the anastomotic leak, it should be guided by the patient's clinical course. Some leaks are asymptomatic and others are life-threatening. And grade A anastomotic leaks that are identified by the radiological findings, they managed by conservatively. And grade B requires therapeutic intervention but not require reoperation. And grade C anastomotic leakage requires re-exploration. Surgical treatment is performed with goal of controlling the life-threatening sepsis. The traditional operation with takedown of anastomosis and endocolostomy may be appropriate, and washout with drain placement, diverting loop ileostomy also be considered. So in conclusion, the Dutch leakage score, CRP levels are good positive and excellent negative predictors of the anastomotic leak. The addition of the procalcitonin to these two improve the predictive value of the diagnosis of the anastomotic leak. Thank you, sir.
Okay, well done. Okay, Niranjan, let us go with students first. Abdul, what do you think of the paper and the way she presented?
Sir, she presented really well, sir, and the topic was good, ideal, but some exclusion factors have factored in more in this. Yeah. Except for that, everything else is fine.
Okay, good. Kavya?
Sir, her presentation, it's a very relevant topic, and not just for in ERAS also, but even in for diagnosing of the leak, and even PCT gives some survival statistics also, prediction also.
Yeah.
Useful examples.
Okay. Pavan?
Hello,
Pavan, what do you think of the presentation and about the topic?
Sir, she presented well, sir. and the topic is also relevant. And what, sir, that's also.
Okay. Hari?
The neat presentation, sir. Slides were good, sir.
Okay. Noli, sir?
Indraja.
Yes, sir.
After this paper, you this grade A, grade B, grade C, you put it in the group. What exactly you mean by that? Okay.
Yes, yes, sir.
Otherwise, this paper is good and you presented very well, Amma. Very good. Thank you.
Sir.
Thank you, sir. Niranjan? Hello, Niranjan.
Hello, sir. Good presentation and good review of literature. Nice topic and relevant topic also. Only thing, it would have been even more better how it helped in prediction, which is. But what happened to those patients when they predicted it early?
Yeah.
So it would have been even more better if they were able to show whether the clinically it was even more relevant, like predicting early reduce the morbidity or mortality.
Yeah. Yeah. Okay. I think so. I think I agree with all of you. I think she presented it very well. It's a good topic. There are
Ravi sir, why the number is less, sir, today for this one?
Sir,
only nine patients, 9 students are there.
ಇವರು ಈಗ ಆಸ್ಟರ್ ಅವರು ಬರಕ್ಕೆ ನಿಲ್ಸ್ಬಿಟ್ಟಿದ್ದಾರೆ. So that may be one of the ಆಸ್ಟರ್ ಅವರು they withdraw from that ಅದಕ್ಕೆ.
Okay, sir. Right. Thank you, sir.
So I think I agree with all of you. The presentation was good, excellent, in fact, and the topic was good. But there are some gray areas. But I think they have answered a lot of questions. But some of them, as for example, Hartman's, and as what Niranjan said, what happened to those patients whom they detected anastomotic leak early, and was there any other outliers who actually they didn't detect early, and was the complication rates higher in those patients? And such thing data, but maybe that is not in the purview of this particular paper. Maybe somebody has to explore that also. Having detected it early, what do you do about it? I think that is another important thing. But I think the most important thing in the era of eras which is now being followed across the globe, I think it is important to have clinical examination is very critical, and then objective data in form of CRP or procalcitonin before these patients are discharged home may go a long way in preventing readmissions, reoperations, and things like that. I think thank you all for a very active participation from everybody, and good night to all. Thank you.
Thank you, sir.
Good night, sir. Thank you.
Good night.